Thank you everyone for coming. I'm Marissa. I'm president of the Harvard Undergraduate GSSA chapter. I'm over at Harvard College, the Undergraduate chapter. And this is our webinar that we were hosting on Pediatric Global Surgery. We're really excited to have some members of World Pediatric Project, which is the first nonprofit that focuses on global, and one of the only nonprofits that focuses on global pediatric surgery. Here with us today, we have Jeff Gallagher, who was one of the co-founders of World Pediatric Project and has been with the organization since its founding for over 20 years. We also have Sarah Iracane, who is the Chief Program Officer at World Pediatric Project and has also been with World Pediatric Project for about a decade. And we also have Alicia Mantega, who is another Chief Program Officer at World Pediatric Project. So thank you to Jeff, Sarah, and Alicia for taking the time to give this webinar today, and I'll let you guys take it from here.
Great. Well, thanks to Marissa and the GSSA for inviting us to present today. We're excited to be in front of you. I know our colleague Ross Silkman actually presented at the GSSA hackathon at Tufts University for the Northeast chapter back in September. So maybe some of you were there and heard him speak about our work, but either way, we're really happy to be with you today over Zoom. We're going to talk a little bit about World Pediatric Project's model for pediatric surgical care. We specifically work in Central America and the Caribbean. Talk a little bit about how our model is unique in compared to other organizations working in this space, and the healthcare delivery system that we have built and some tools that have helped us do our work. And of course, look forward to answering questions you might have. I'm actually going to let Jeff give a little bit of an introduction here. As Marissa said, Jeff has been with the organization since its founding and can speak to our vision and history, as well as how we have developed into the organization that we are.
Hi, I'm Jeff Gallagher, and it's a pleasure to be speaking to you all. I only go back to history if there's a point to be taken out of it. And there's an interesting one here. When the organization started almost 20 years ago, the original vision was, hey, let's take over a hospital that closed in the United States and bring children here to give them the care that they need. Because very close off our shores, in other countries and other economies and societies, there are children who are dying every day, whose lives are being compromised because they can't get the care that's only an hour, 2 or 3 hours away by flight. So let's bring them here and do it. And it took us about a year to run into a brick wall and get a different idea in our head. And that was, rather than build or take over a big physical facility here at great cost just to keep the lights on, what if we made a virtual hospital for children that covered the region? We wouldn't be limited to bricks and mortar. We wouldn't have to worry about all that equipment. Let's go down there. And they have healthcare systems. They do some surgeries, and every community and every nation is different. Let's figure out what the heck they need. And then in a concept I know Sarah and Alicia will talk about later, what is needed to complete the circle of health and add the tertiary care that those children need, and let's just provide that. And if we can't provide that there right away, or even after trying for decades, well, then let's bring them back up to states all across the United States and provide it. So this notion of a virtual hospital for children rather than a physical one, because it's the people and it's the services and it's the smiles and it's the communication person to person that really brings the care and the follow-up that the young people need. So that was a vision. And I'll say one other thing and then I'll hand it back over. For the first 16 years, we were basically rowing a canoe upstream, because in the world of global public health, surgery was looked down upon. It was, the numbers had been run, the priorities had been established, and surgery, particularly pediatric, but in global health broadly, but in pediatric in particular, surgery was at the bottom of the list. It was a first world solution that was blind to the real needs of the communities and the people that we were dealing with. And it was only 4 or 5 years ago, as you may well know, that there was a sea change in the opinion of the global public health community to the role of surgery, prompted by the Lancet article and study. And more will be talked about that later. But from being from the people like Sarah and Alicia and the others who rode upstream for all those years to create this extraordinary, incredibly complex process and organization which brings very simple, impactful care to kids. They were rowing upstream, and now the world looks at it and says, oh yeah, that's great. The numbers are terrific, yeah. And so you can learn from the lesson. You can learn lessons from how they built this over the last 20 years. And they're dying to share those lessons so that you and the people you work with and organizations to come, our organization, but other organizations to come, can recreate this and reach more and more kids. That's it.
Thanks, Jeff. Just a brief history. Our organization was founded in 1999. Originally started out of a Rotary initiative, but became an independent 501c3 organization, incorporated in 2001. We currently have 2 U.S. offices, Richmond, Virginia, and St. Louis, Missouri. I am in Richmond, and Alicia is in St. Louis, so you've got both of our offices on right now. We also have several international offices in some of the countries where we work, including St. Vincent and the Grenadines, Belize City, St. Lucia, and then we have additional part-time staff and representatives in several other countries. So we have a wide footprint and staff kind of scattered all around that make this happen. And we'll get into a little bit more detail about our volunteer network in a little bit. But a little bit of context for everyone on the call. Why does WPP exist? A lot of what I'm going to say here is not news to you all, as you guys are passionate and interested in global health and specifically surgery, so you're aware of the need out there. But there are, some statistics from the Lancet Commission on Global Surgery that came out several years ago that are really impactful in kind of painting the picture of why WPP's work is needed. And as Jeff mentioned, for a long time, global surgery was not much of a topic in the global health arena. It's only been recently, I would say, in the past 5-6 years that we're starting to see more organizations and funders want to focus on this work. So surgically treatable conditions represent 1/3 of the global burden of disease. 9 out of 10 people in low resource countries lack access to basic surgical care. When we look at the pediatric space, it's probably 9.5 out of 10. One of the challenges with pediatric global surgery is that there really is no good baseline data. Data is not really being collected on pediatric need, so it's hard to assess impact made. But we do know that children, as in many countries, are in a more vulnerable position in terms of access to care. Again, some additional statistics from, I think some of these are from the WHO, 17 million lives lost annually from conditions that require surgical care. And without investment in surgical care, low to middle income countries face an estimated US $1 trillion in lost GDP. So there is a great argument to be made for the economic impact of investing in developing surgical care in these countries. Loss of productivity and loss of life go on to vastly impact these countries economically. And we're starting to see governments and partners that we work with recognize that, and they are wanting to make their own investment in their countries to develop healthcare systems for surgery as a way of boosting their own economic development indicators. And so why do some of these statistics exist? Of course, you all are very familiar, I'm sure, with the landscape and where we're working and the challenges. I mean, health expenditure per capita, vastly different in Central America and the Caribbean, where we focus our work, versus in the United States, as well as a shortage of healthcare workers. This is a combination of small population countries, brain drain from people migrating to other countries for higher paying work. We see a staggering shortage, particularly in nurses as well as in physicians. Also, it's important to point out in the pediatric space, many of these countries have a dire shortage of pediatric subspecialists. So we may have general practitioners or adult trained surgeons, but what they don't have is anyone who has any advanced pediatric subspecialty training. And you all know that children are not just little adults. So they require a different set of specialty skills to properly care for them. And in many of the countries where we work, those individuals are not available or they're otherwise overwhelmed with way too many cases and not enough providers. Again, you know, the societal benefit in terms of investment and the ROI generated, the return on that investment. You know, there was a article published recently that was evaluating the impact of the Gates Foundation, and they invested $10 billion in healthcare delivery, and they calculated it generated $200 billion in social and economic benefits. So people talk about investing in lower and middle income countries, and our argument to be made is that investing in the healthcare of those countries is a great way to invest in the economies of those countries. We're really committed to aligning our strategic vision with the goals of the global health community. Our programs work to support many of the sustainable development goals that are in flux and moving forward, specifically those related to SDG number 3 and some of the specific targets I've listed on this slide. We have a close partnership with the Pan American Health Organization, which is the Western Hemisphere branch of the World Health Organization, as well as different regional and intergovernmental organizations working in the health space, so that we can make sure that the programs and goals that we are developing are in sync with what is being advocated both at the international and at the regional level. I'm going to talk a little bit about our approach and how our model for care delivery might be different than other organizations. I'm going to turn it over to Alicia here in a moment. So Jeff mentioned completing the circle of health, and we see our role as providing the missing tertiary care to complete the circle of health in the countries we work, so that children have access to all levels of healthcare that they need to live full and productive lives. This tertiary care, this last piece of the pie, is what is often missing in the countries and hospitals where we work. They have access to primary care. Children are immunized. You know, children have access to decent nutrition. They've made advancements in different communicable diseases. There's secondary care available. Hospitals exist. Imaging is available. Pharmacies, lab work. What they don't have is that advanced pediatric subspecialty care. And that is where WPP attempts to come in and complement and support the existing healthcare system to close that gap in the circle of health. And by nature of this model, we have to work very collaboratively with the local healthcare workers in the countries where we work. A few components of our model to highlight. Long-term engagement and continuity of care. We are not a disaster relief organization. We build long-term programs in the countries where we work. We stay in those same communities and countries for 15, 20 years. And by virtue of doing that, we develop the cultural competency to understand each unique community and respond to local needs in a very specific way. WPP engages in multi-specialty care. So we provide surgical care to children in a variety of specialties versus focusing in one specific specialty area. We are able to address a wide variety of healthcare needs that children in a community have. It also allows us to cross-refer patients. So for example, we're able to treat children like this little girl who has spina bifida. She may need urology services, neurosurgery, orthopedic bracing support, and we're able to provide all of those services under one healthcare organization umbrella. We have a combined approach in that we are providing direct patient care today and capacity building. This is a core component of our sustainability efforts. We want to heal children in need of care today, but we recognize that the priority and emphasis for future care to improve must be on training the local staff that is available, teaching them pediatric surgical skills and finding ways to support other capacity building in their hospitals and communities. Oops, skipped that one, but go back here, guys, sorry. The last one is a regional focus on depth, not breadth. And what we mean here is that World Pediatric Project is highly focused in Central America and the Caribbean. We've been in that region of the world since our founding. And while we've expanded within the countries where we work and subspecialty areas, we've not strayed away from this regional focus. We feel that it is more important to address all of the needs, or as many of the needs as we can, in the partner countries where we work and the communities we serve before we look elsewhere. Our former CEO used to say that it's not about pins on a map. She didn't care how many pins you had on your map of the world. It was about the impact that you were making in the countries that you chose to invest your time in. And we feel that is a core part of our model. I mentioned that we have a tailored custom approach to each unique local need, and Alicia's going to talk a little bit about that when we talk about our traveling surgical teams. In our small population countries, in the Eastern Caribbean and Belize, we have a different innovative model that we've developed. In the Eastern Caribbean, we're centralizing care in small island developing states into one surgical hub for the Caribbean, really trying to develop a healthcare system for a challenging region of the world where we have small populations that are geographically isolated, but also economically disadvantaged and really struggle from and facing many barriers in access to care. So we've tried to develop an innovative model in that region of the world and in our small population countries. In our large population countries, we have a collaborative model where we're developing more local capacity. There are pediatric subspecialists in these larger countries, Honduras, Guatemala, Dominican Republic, and they work with WPP in training programs and in other ways where we support their individual efforts and help build their local capacity. And Alicia can talk about that in a little bit as well. The last component I want to highlight about our model is a robust monitoring system that we have through a custom patient information and reporting database that was developed over about 10 years. We have prioritized investment of time and money into building our own information system so that we can track our children and the healthcare services that they need. We can connect them efficiently to care and also report on trends that we're seeing. And we'll talk about that in a little bit more detail as well. You've heard me mention our region of focus. We work in Central America and the Caribbean, specifically the countries you see listed here. On occasion, we may serve children from countries outside of this region and of these identified partner nations, but this is our dedicated region of focus. We have a vast partner network and team of medical volunteers that make this happen. Part of the sustainability of our model is the diversity of partners that we engage to make it all happen, as well as the volunteer support that comes from around the United States. So these are just a quick snapshot of medical volunteers in hospitals with which we partner, as well as other nonprofit organizations. We definitely could not do this in a silo. Again, a quick snapshot of just a few of the key partnerships that we have. Certainly this list is not exhaustive by any means. And maybe some of the hospitals or universities that you all are currently attending or affiliated with are some of our partners. So what are our core programs and how are we meeting the need? We have 3 core programs that we'll talk about. The first is our International Teams program. These are our traveling global surgery teams. They provide both surgical and diagnostic care. Prior to the COVID-19 pandemic, we had about 60 teams traveling each year, providing care to about 3,000 children. An additional core program of ours is our US and International Referral program. And you heard Jeff speak about this. This program exists to serve children who cannot be safely or adequately treated through visiting teams. So if we identify a child that needs advanced care, we have a separate program for those children. And then capacity building programs. Our capacity building arm of our organization, our non-surgical arm, is currently focused on neonatal care training in 5 countries. I'll mention our US referral program quickly. Again, this is our program that exists to care for children who have exceedingly complex or urgent care needs that cannot be treated by a visiting team. We have close to 20 US hospital partners across the country who accept children for us into this program. We also can refer children internationally to advanced centers in places such as Martinique, the Cayman Islands, and Guatemala City. A patient and a guardian will come and stay for an average of 3 to 6 months. Our current emphasis is on cardiac, orthopedic, craniofacial, general surgery, and other urgent care needs. We can always monitor and track all of our patients and are able to provide follow-up care to them when they return to their home countries through our traveling teams. So the two programs work in close coordination. Little babies you see here are the Tapia twins who had successful separation surgery at VCU Medical Center in Richmond back in 2011 from the Dominican Republic. I'm gonna, Alicia, take it from here and talk about our international teams program, which is likely what a lot of you are interested in hearing about.
Thanks, Sarah. As we mentioned, our international teams program is our program in which medical volunteers from the United States travel to our partner countries to provide surgical specialty care. We do this in over 15 specialties, and those specialties change and have grown depending on what our partner countries request of us. So to give you an example of those specialties, we currently are sending teams in scoliosis, orthopedic general surgery, upper extremities, so just hands and elbows, laparoscopic surgery, neurosurgery, craniofacial surgery, plastic surgery. So we really do kind of cover the spectrum of tertiary care that could be needed in a small island country, for example. It is imperative that we collaborate with the ministries of health and the local partners, and this looks different depending on which of the countries we're talking about. A standard is that we establish what the credentialing criteria are for international medical volunteers to work in a country, and those are set by each Ministry of Health. And then we work with our local staff or partners to make sure that every single WPP volunteer who's in the clinic or in the operating room meets the credentialing requirements. And sometimes that means that, you know, our fellows, for whatever reason, can't go because they don't meet those credentialing requirements. We also collaborate extensively with local partners, and sometimes our staff cannot find everyone, make sure that they can get transported to our clinics, make sure that they have accommodations so that they can stay for a week if need be. There are just so many moving parts to organizing international surgical teams, and so that's why we have international local partners who help us fill those gaps. We do have staff, though, that work very closely with local physicians and Ministry of Health in terms of advertising our clinics and making sure that relevant physicians and nurses and medical staff know what teams are coming when so that they can participate if possible. We do have a strong emphasis on cultural competency, and I'm sure obviously you all must know what that means and appreciate the importance of cultural competency. For us, the reason why it's exceptionally important is the next bullet point, annual consistency. Our teams come year after year, and without mutual respect amongst every single medical volunteer that we have, if it's the nurse or the physician or the physical therapist, whatever the role on a team is, without acknowledging the strengths of our collaborators, without that awareness of, you know, you're working in a different environment and they might have limited resources, but they're doing a whole lot more than, you know, maybe we could do in the States with a whole lot less, you know. So it takes that kind of approach and humility and cultural competency in order to be a successful WPP volunteer, because we do ask teams and physicians to sign up for a program, not just for an in and out a week of service. And that's something that I would encourage you, once you become fully fledged professionals in your field, I would encourage you to seek out organizations that do require that you commit to more than just a one-off surgical program. We have staff across the US, of course, Sarah and I are two of those, And in our international offices, we coordinate the logistics. So what that means is we make sure that we know who's coming. We have, if it's, for example, an orthopedic surgical team, we have all of the labs that we need. We have the x-rays that we need so that the surgeons can assess the children before they travel to the clinic and make sure that they're appropriate surgical candidates. And then once they're there, we make sure that they have 100% of the supplies that are needed to provide the surgery that has been determined for the patient. So there's quite a lot of collaboration with partners both in the United States and then also in our partner countries to make sure that all of those logistics can be met. And then finally, and something that we're all very proud of is that we have an extensive monitoring database, as Sarah mentioned. We do keep very close track of surgical outcomes and quality of care measures. For example, one of our policies is that within 30 days, there's a full report of every single child who received surgery. So of course they receive check-ins along the way, but we need to see at 30 days how each child is doing. And we have our chief medical officer examine any complications that might have arisen to make sure that it wasn't because of something that we could have controlled. So we do take surgical outcomes very seriously, and we would not consider a partnership with a country or hospital or physician unless they could adequately provide follow-up care and monitoring that we need.
I'm trying to change it, Alicia. Hold on one second.
Okay.
There we go. Okay. There we go.
So a couple of best practices that as an organization we're really proud of is that we emphasize so much relationships and working alongside local physicians. And this looks very different in our small population and in our large population partner countries. So I'll give you an example of what we do in each setting. So in the Eastern Caribbean, our hub of surgical care is St. Vincent and the Grenadines. It's an island that's surrounded by other partner countries of ours, St. Lucia, Dominica, Grenada, St. Kitts, etc. And so when we have a surgical team come in, let's say if it's a orthopedic specialty team, we invite local physicians to come, and we even help provide a stipend so that they can attend the team and scrub alongside and take care of whatever patients that are coming from their home country, so that not only are they interacting with our surgical team, developing those relationships, but also honing some skills that maybe they have experience in the adult orthopedic realm, but there just isn't that economy of scale to support a pediatric orthopedic specialist. And so this exposes them to some surgeries that otherwise they might not be able to participate in. And then in building that relationship, that means that our local partner physicians are comfortable sending us questions throughout the year that we can then share with our physicians, or sometimes they communicate directly with WPP physicians on other questions that they have about different patients or even the same patients. So again, that relationship and that working alongside local physicians in our small partner countries is something that we're very proud of. In our larger population countries, we'll take Honduras, for example. We work with the only pediatric spine surgeon in the entire country. And he received an excellent training at the Shriners in Mexico, fully competent and capable of performing spine surgery. The only problem is that they don't have neuromonitoring, they don't have access to implants, they don't have those specialty supplies because they're too expensive and there's no supply chain for them. So what happens is his skills get rusty. So what the program that we've developed to address this is that we have sent in rotation the same surgeons for several years, several times a year, so that this Honduran surgeon receives the practice and skills necessary, so that once we are able to help establish the, make sure that they have the equipment and the supply chain to produce the implants that they need, that he'll be ready to go. So that, again, that wouldn't be possible without this strong partnership between the US surgeons and our Honduran partner. And Sarah, I think we lost the PowerPoint.
Yeah, I know. Hold on one second, guys. Give me 1 second. I'm not sure what I just did. Hold on 1 second. Get it back up. I was trying to check on the Q&A and I lost my screen. 1 second, guys. Okay. Are we back? Sorry, guys. Bear with me. I apologize, Alicia.
Hey, listen, while Sarah's doing that, in one of the earlier photos, there was an older gentleman, the bedside of a child, white-haired. That was Aldo Castaneda, and I don't know if you, the people on this call are familiar with Aldo, but he was one of the giants of pediatric cardiac surgery. He's Guatemalan, and there he is. He was trained in Europe, residing in Guatemala, recruited to the University of Minnesota when they were inventing open heart surgery, then became chaired professor at Harvard Medical School, the chief of pediatric cardiac surgery, and then the chief of all surgery at Boston Children's. And then when he retired, went back to Guatemala, began a teaching institute there and treating children with cardiac surgery, and has been a long-time collaborator of ours, not only in Guatemala, but in training surgeons from that region to then be used elsewhere in the region. He is if you don't know his story, Aldo Castaneda, please look it up. It's just extraordinarily impressive, the difference one person can make.
Absolutely. Thanks, Jeff. Alicia, I'm gonna get you back 1 second here. There we go. I won't touch the screen again.
Okay. I mean, it opened the door for an amazing story. So thank you, Jeff, for sharing that. Also reflects the caliber of our medical volunteers. They are top notch, and I would like to emphasize that we are extremely proud and lucky to have the medical volunteers that we do. And so the second point on a best practice that you might keep in mind as you move forward in your career in global surgical care is to not strain the local resources, and that looks differently depending on where we are. Sometimes the responsible thing is to source local supplies from using the local supply chain, and that is if the end goal is to produce a sustainable program, which in our large population countries, sometimes that is a realistic end goal. In our island countries, not straining local resources means that we bring everything from a piece of suture to a drill to a operating pack, and even WPP collaborated with the funder to create a third operating theater within the hospital that we use, so that we are not using local OR time that is infinite. It's in demand, and the operating facilities are limited in a lot of the countries where we use. So it just takes a responsible look at how are we straining the local system and providing these additional services, and how can we mitigate that in a responsible way. I've touched on building local capacity, but I'd like to emphasize that's not just with our surgeons. We have several programs, especially I'm thinking our Honduras cardiac training program, that every single player that plays a role in a heart surgery for a child, from the pre-op to the post-op nurses, every type of physician that's involved in their care, the anesthesiologist, everyone has a counterpart. And so the week is not focused as much on the numbers of treatment as it is on the training that occurs while you're treating a child. We do listen to what our local partners need, so that means we don't dictate what specialty services we provide. We kind of have this push and pull where we wait and see what it is that our local partners request of us. Another way that we determine which teams come, if we happen to see that our local partners are referring a lot of children to the US for treatment of a specialty that, for example, in Guatemala, we were receiving a lot of requests to treat children in the US for craniofacial disorders. So we put together a craniofacial surgical team to send to Guatemala, because that's the need that we saw emerging from the country. So we try to be very thoughtful about what services we provide. We do uphold the US standards of care, so that does mean that we might have to have difficult conversations with our partners if they're used to mission groups, especially those big parachute groups with 100 people who come in and maybe have 2 operating beds active in the same room. That's not US standards of care. So we don't adhere to that. We make sure that we follow the best practices that are established here so that our surgeons can confidently say that the surgeries that they provide are the same level of quality of the surgeries that they would provide at home. And then finally, we do create space for the local team. And what that means is we keep our teams as small as possible. So we really don't allow residents to travel. We try to keep the teams as small as possible so that local residents have a place at the table and that local surgeons feel comfortable collaborating with their international counterparts.
Thanks, Alicia.
Sure.
Yeah, I think Alicia touched on a lot of components that are not only, you know, our best practices, but also what we think is really important in considering how you develop your own sustainable engagement in global health and global surgery moving forward. A quick comment about our capacity building programs that are outside of our surgical teams. Of course, we like to think that we're building capacity with every team that travels. We do have some programs that are non-surgical in scope. Currently, we're focusing that area of our programming on neonatal health, neonatal care training. This came in response to some ministries of health who reached out to WPP for support in training doctors, nurses, and midwives as part of their national health plans to reduce under 1 mortality. So we've partnered with the Pan American Health Organization and a few others to launch training programs throughout the Eastern Caribbean. I won't spend too much time talking about that since we're focusing on surgery today, but it is an important and complementary arm of our work. You know, there is a surgical connection with neonatal health, and so we're able to reinforce multiple components of the pediatric health system through these 2 programs. Alicia and I have both talked about the patient information and reporting system that we have, and I think it's one of the things we're most proud of. Maybe second to our amazing medical volunteers would be this system that we use to create the WPP vision and model for care. So again, I mentioned this is a custom tool that was designed over the course of 10 years and is still undergoing design modifications every day. And I honestly think that this system is one of the reasons that we are able to respond to the COVID-19 pandemic in the way that we've been able to. It's allowed us to pivot and continue to monitor and evaluate our patients even at a time when we can't get our volunteers into these countries physically. It started as a case management tool, as a way to connect our patients to programs. We have volunteers traveling in a lot of different specialties. And so we developed an information system that allows patient records to be stored and then shared in report format with various volunteers who are traveling. Over time, it's grown and grown. We now have over 50,000 records for more than 15,000 patients. It's a pretty unique treasure trove of pediatric surgical data in a region of the world that is otherwise not collecting any data on pediatric surgical volume. We also have a report center component of this system where we can monitor our program activity and generate custom reports as needed. So it's a multifunctional tool. It not only is kind of like an EMR, a patient management tool, but we also use it for organizational reporting and trend analysis so that we can make strategic decisions about how to expand our programs. Again, I mentioned the case management. This is a snapshot, kind of what our previous patient portal used to look like. We had just rolled out a new system actually a couple months ago, so we're transitioning to a new platform, but the core foundation is the same. We'll document anywhere from 2,500 to 3,000 children's services in this custom database. Again, a child like Casey you see here from St. Vincent, he'll see anywhere from 4 to 5 teams each year. And this tool allows us to keep that care seamless. All of his records are stored. His local providers can access those records if they need to. Our volunteers can access them. Since we're dedicated to multi-specialty care, it's important that we can do this systematically And more than 30% of our patients receive care in more than one specialty. And that's really unique in global surgery. Alicia mentioned we're not a parachute in, parachute out organization. We're building a healthcare delivery system. In order to do that, we need to be able to cross-refer patients and address all of their care needs. We use this tool beyond, clinical case management, but also to know the outcomes beyond just the activities that we're organizing. So we can run any number of reports. We look at our referral networks to see where are we receiving new patient referrals from? What districts do maybe we need to increase our community health worker presence? Where are we missing children? What are common diagnoses we're seeing in a certain subspecialty area? Is there an underlying health prevention issue going on that we need to look at? Are we starting to see new referrals in an area that we haven't treated before? Do we need to do more fact finding? Alicia mentioned surgical complications. So we can track quality of care measures also through this database. And we share this information beyond just our own internal reporting. We provide reports to ministries of health, to our physicians that we partner with. We're really increasing, as of late, a lot of our supporting academic research of our physicians and others who want to publish or submit peer-reviewed journal articles about their work with World Pediatric Project, and this system provides valuable data. And of course, we always are willing to share information with other NGOs who are wanting to support patients in the countries where we work. I'm going to let Alicia talk a little bit about some of the academic research projects we've worked on, as this is one of her areas of interest and specialty. So Alicia, I'll kick it over to you.
As Sarah mentioned, several physicians and researchers have been interested in using our data as a platform for showing if and how the work that we do is effective, and perhaps forecasting, creating evidence that might be needed to encourage best practices here or elsewhere. So currently we have two studies that are ongoing about the cost effectiveness of global surgery in our partner countries. One study is out of William and Mary, and the second is out of Washington University in St. Louis, and both are using data from our surgical programs in the Eastern Caribbean, that take place in St. Vincent in the Grenadines, to evaluate whether or not our approach is cost effective. In general, we also have had a lot of questions about, is what we're doing evidence-based? And the only way to know is to have evidence. So there's a lot of evaluation of surgical treatments in low-income settings. As I'm sure you all know, there's very little literature that's produced from low and middle income countries, especially the ones in which we work with the smaller populations. So that evaluation is crucial in order to say and claim that what we are doing is evidence-based. Observational studies on disease trends, like Sarah mentioned, is something that is made a whole lot easier by our patient management system. And then implementation of training programs and lessons learned. This is something that we do like to report back on, just so that other nonprofits know exactly what type of work that we're doing, so that they can hopefully replicate our best practices. And of course, we look to the literature whenever possible when we're determining how to best, tackle these complex problems. And again, some of our collaborators are out of VCU, St. Louis University, Washington University in St. Louis, Johns Hopkins, and hopefully, many more as physicians take an earnest interest in sharing the work that we do and hopefully helping us determine whether or not we are taking the best approach to tackle these complex problems.
Thanks, Alicia. I'll close with just a couple last slides here. A lot of times people will say, okay, but what's the impact here at home that you're having? And we believe strongly that the work that we're doing does strengthen the pediatric health communities here in the US. Our volunteer surgeons say that their work with World Pediatric Project has made them a better physician here at home. Here's a quote here from Dr. David Lanning, who is a past board member and our our current medical director of the organization. He's a pediatric general surgeon at VCU here in Richmond. And he said that working with WPP has been transformative for their health system. The doctors and nurses have become global leaders in specialty surgical cases, and the volunteer opportunities provided are excellent for our employee and student recruitment and retention. And this is just a snapshot of Richmond alone. We've provided more than 575 surgeries to over 400 children since 2001 here in the Richmond community. So the impact that World Pediatric Project has had here on physicians and nurses in our own community is great. And many of our volunteers credit their work with World Pediatric Project as making them more adaptable, more able to think creatively about treatment approaches, and oftentimes they learn things from their counterparts in other countries. They are able to learn new strategies for caring for children because of what their counterparts are able to do in low resource settings. So it's a really beautiful exchange of knowledge, and there definitely is an impact here at home. There is also the efficiency of our model from the sense of philanthropy. This doesn't happen without generous, fundraising and donations provided. So every dollar donated through the volunteer efforts of our surgeons and nurses mobilizes $5 in pediatric medical resources. Because our volunteers give their time, and we have charity contracts at many hospitals, we're able to really leverage every dollar given to help more children. So that totals about $27 million in services annually that we're able to facilitate, which is pretty remarkable. Jeff, I'll let you close if there's anything else you want to say about our milestones after nearly 20 years, and then look forward to opening it up for questions.
Thanks, Sarah. Those things are pretty self-explanatory to take a look at them. Not everything that counts can be counted, and not everything that can be counted counts. And these are things that can be counted, but the impact on the communities and the children, the difference you make in lives, this organization has made, and all the volunteers, the way it changes your view about yourself and your colleagues that you travel with, the way that it opens up entirely new dimensions of empathy and sympathy and understanding, so that you come back and just think differently about people and problems. Just transformational in so many ways we can't measure. And I just say, looking forward for you folks who are still on your path. Sarah and Alicia mentioned the physicians and medical professionals who participate to a person say that they're better in their profession for it. They confront things they never could have confronted here, sometimes in low resource environments, which challenges their creativity. The hospitals and the medical centers in which they perform, and who also volunteer their hospital rooms to us in the United States, they have come to love our programs, not because they recruit talented young people like you who want to get involved, but also because it knows it gives their providers an edge of excellence and dynamicism and creativity that they can offer to their communities, and the communities understand. So looking forward for you, I think it's a great thing to follow your passion and be involved for your own profession. For the organization, the rich data is leading us now to discoveries and in directions we don't even know about yet. We're getting more and more sophisticated, nationally and globally sophisticated partners to help us look at our data, and that's going to be really fun and provocative and challenging to follow. The role of technology is increasing. COVID has even squeezed that. And so the extent to which we can integrate telemedicine into this approach that we've developed, or mobile technologies, handhelds, so that we can supplement the care to make it even better, is something that we're looking at in an accelerated way. And your generation will grab that and go farther with it. But then the last comment, and then I'll stop, is with all that technology and all those accomplishments and all that data and everything, it's been far more like growing a garden than building a building or inserting a medical device. And maybe the most unmeasurable but proudest thing for me, and I think for many in the organization, is after all those numbers up there and people like you going back day after day, to see the trust that has been earned, which has allowed us to do more to serve more children. And that doesn't happen overnight. And you have to be patient. You have to love these people and what you're doing, and it'll come. So a lot of what's been done over the last 20 years has just put in a position where Alicia and Sarah and others working now can do it, and where you can do it even better in the future.
Thanks, Jeff. There's not a more eloquent close to the presentation than that one. Jeff hit the nail on the head. It's a real honor and a privilege to do this work, and the trust that our families and partner physicians place in us and in our volunteers is something we take very seriously, and we're committed to doing this work at the highest standard. It takes years to build that trust, and it can quickly go away. So we take our relationship building and stewardship very seriously. And it is just, we're very fortunate to be in this line of work, and look forward to, you know, your questions. And of course, know that you all are going to go on to do great things as well.
Thank you so much, Alicia, Sarah, and Jeff, for taking the time today to talk about the incredible and inspiring work that World Pediatric Project is doing. We are going to open it up to questions from the attendees. So you can either drop your questions into the Q&A section on Zoom, which should be at the bottom of your screen, or if that for some reason isn't working for you, also the chat box. Okay, we have one question from Preston. Thank you, Preston. The question is, in terms of centralized care for small island developing states, is that one system for each island or one system for all small islands?
That's a great question. So what we've done is we've developed a surgical hub for the Eastern Caribbean on the island of St. Vincent. And Alicia mentioned that we had outfitted our own operating theater. What we realized was that all of these children, by centralizing all the islands and looking at them as one kind of population set, we could create an economy of scale. So we send surgical teams into St. Vincent, and they operate in a WPP operating theater, which helps us not constrain local resources, but we're able to service children from the entire surrounding region. The government of St. Vincent and Grenadines, through our partnership, has opened up the hospital to treat children from all these other islands. So we will do decentralized diagnostic clinic outreach in all the islands, but we were trying to centralize all the surgical care from an efficiency standpoint on the island of St. Vincent.
One question that we had through the registration form before the webinar was, how can we get involved or gain further experience in this field?
Alicia, do you want to take that one?
Sure. So that's kind of a two-part, from my perspective, answer, and maybe Sarah and Jeff would like to add on to what I have to say. The first thing is that we, this may happen, I'm sure this will happen naturally, but the first step to be participating in global surgical care is to become an expert in in surgical care in your own country. So we're not really, you know, of the mindset that you should develop your skills, that you should do something abroad that you wouldn't do at home. In fact, that doesn't really seem ethical. So we encourage you to develop your skill set and look at those pediatric subspecialties that do need more physicians, and consider, even if they might not be the most lucrative, consider following, you know, choosing that career path is one that's most needed. But if you're interested in becoming involved now, of course, things have become a little bit challenging, of course, because of COVID. In terms of our volunteer program, we do have children who come to the US, and we have children in the US right now in St. Louis. And throughout the year, we'll have children in Richmond, in Spokane, in Philadelphia, in Texas. You know, it just depends on the time of the year. And so normally we would say we would love to have you as volunteers to help accompany our children and their caregivers through treatment. Now, unfortunately, we can't do that just because it's too risky. However, so many of our surgeon volunteers absolutely love teaching and talking about what they do. So if you have any questions about a pediatric subspecialty in which we we interact. So if you want to become an orthopedic surgeon and you have questions about what does that look like in a low resource setting, we would be absolutely thrilled to connect you with our surgeons, and they would be absolutely thrilled to answer your questions. And then finally, I know that as a group, some chapters have helped fundraise so that we can provide treatment for cases. We have a long wait list of children who need to come to the US for care, and we just, our resources are finite. So if you wanted your group to adopt a child and sponsor their treatment, then of course we would love to keep you updated along the way as they progress. Jeff or Sarah, any other thoughts on how to get involved?
That was it. I mean, Marissa may be able to give some examples of how she's had her student group at Harvard has gotten involved with World Pediatric Project specifically.
Yeah, so our group is all undergrads, of course, and so we don't have the same ability to contribute in terms of medical volunteers, but ways that we have found that even undergrads can get involved is we are developing a care package program with World Pediatric Project. So for the patients that are coming to US partner hospitals and staying for several months at a time with their families, we put together little care packages, which is some items to kind of help the families and the kids, like toys for the kids and supplies for the parents, to kind of make that trip a little bit easier for them. And we're also now looking with the pandemic, and I've been talking about maybe doing some sort of virtual volunteering program where we could pair kids that are in the US and can't have as many visitors.
If you're interested in any of those opportunities, feel free to reach out to us. Marissa, I did get one question sent to me via chat. If I can go ahead and answer that one.
Yeah.
Okay. You mentioned that you have been training surgeons to be ready to perform more specialized surgery when supplies, et cetera, are available. Do you have any success stories from this or examples where this has been effective? In other words, have you ever been able to see the full transition from your team performing surgeries to the local teams? That's a great question, and it's really challenging to get from that point A to that point B. But I do have a great example. In the Dominican Republic, World Pediatric Project led a consortium cardiac surgery training program to build a pediatric heart surgery program for the entire country. We worked with organizations from around the US, and over the course of about 10 years, we're able to build the capacity at a semi-private hospital in Santo Domingo to build a pediatric heart surgery program. When we started our work in 2004 with this program, the local team was doing about 2 or 3 cases a year independently, mostly PDAs and very straightforward low intervention cardiac work. Last year, I think they did close to 500 surgeries independently. So that is a hallmark flagship program that we're so proud of. And World Pediatric Project led the training efforts there, but on the other side, we had really dedicated partners, and we had a commitment from the hospital administration who invested in developing that program in their own way as well. They sent surgeons and specialists abroad for further training at places like Unicar, or Aldo Castaneda's hospital, which Jeff mentioned. They also committed resources to developing a supply chain. So they were willing to invest as well on their end. And so it really does take that level of multifaceted partnership to build these programs and transition them to become independent. We continue to stay in touch with our partners in the Dominican Republic, more in a consultation role now, but we don't actively send surgeons to that hospital anymore. So I think that one is a great example of when the right players come together, you can really, quote unquote, work yourself out of a job. Jeff?
One of the other right players in that combination was David Ortiz, the world famous baseball player for the Red Sox. And WPP actually still is involved in the David Ortiz Children's Fund, and sponsored so many surgeries in the Dominican Republic and training, and was our most loyal, devoted fan as well as player for that for many years.
It looks like we have one question in the Q&A, which is, with the advent of novel global surgery and residency/fellowship programs in the US, in recent years, is WPP partnering with any of these programs to provide US residents and fellows with the chance to engage in global surgery prior to their work as attending physicians?
Sure, I can answer that, and then Alicia may want to answer that one as well. I will say that we don't have any formal relationship established with a specific university. However, on occasion, it's a case-by-case scenario. We do have surgeons who have brought fellows or chief residents on specific trips to help expose them to global surgery outreach. Like Alicia said, our motto is kind of, if you don't do that work in the US, then it's not appropriate to be doing it on the teams that we send. So the involvement in a hands-on capacity in that way is really limited to surgeon invitation only for fellows and chief residents who have an expressed interest and passion in pediatrics globally, and have demonstrated the skill sets to be able to perform safely in that low resource environment. So we don't have a formal relationship, but on a case-by-case basis, we do encourage up-and-coming global surgery stars, I'll say, to join our teams. Alicia, anything else on that?
I think you pretty much covered it, but I would like to kind of brag about our volunteers again, and that the fellows that are invited are ones that our surgeons do feel have, exhibit a lot of promising qualities. And one of our fellows from, I think it was around 8 years ago or perhaps longer, he recently led his own surgical team, co-led a surgical team to Guatemala. So we're just so happy that, the fellows that have engaged have remained involved in our programs.
Hey, I do want to be respectful of everyone's time, so I think that that's a good place to wrap up. Thank you so much to Alicia, Sarah, and Jeff for taking the time today to give this webinar. It's really been inspiring to hear the story of World Pediatric Project and the amazing work that you have already done, and how you're building for the future. So thank you again. And thank you to all of the attendees for taking the time to listen.